everyone, and welcome to the Delray Beach Chamber of Commerce's weekly webinar. As always, these webinars are recorded and they are posted to Facebook, the Chamber YouTube, and our website underneath the webinars tab. Today's topic is going to be skin health and the science behind cosmetic products and treatments, presented by our very own chamber member, Delray Dermatology and Cosmetic Center. We have Dr. Francesca Lewis, who we all love here today, who is a board-certified dermatologist and founder of Delray Dermatology and Cosmetic Center. She will be discussing how to achieve and maintain healthy skin, skin cancer prevention, and sun safety, which we all know in Florida and everywhere, of course, but here especially is super, super important, as well as the science behind at-home cosmetic products, as well as an in-office cosmetic treatment. So we want you to stay tuned to the end because Dr. Lewis is going to be available to answer any questions that you might have. So at this time, we're going to go ahead and turn it over to her so she can start her presentation.
Perfect. Thank you guys so much for having me. So we're going to load up the presentation for you. Give me just 2 minutes. Perfect. Okay, good. So a little bit about myself. I am a board-certified dermatologist, and I did my undergraduate degree in psychology and neuroscience at Vanderbilt University and graduated from Emory University School of Medicine. I was a member of the Honor Society Alpha Omega Alpha and chief resident in dermatology at the Medical University of South Carolina in Charleston. So I specialize in medical as well as cosmetic dermatology. And I started the practice here in East Delray about 3.5 years ago. So today we're going to touch on a variety of things, and I picked this topic because these are common questions that I get asked on a daily basis by patients. So first off, I think that this is an intuitive one, but let's discuss why daily SPF use is so important for skin health. A lot of times when I ask patients if they're using it, they sort of brush off that question and tell me they use it, especially when they're at the beach, but not on a daily basis. So first off, a little bit about the UV spectrum. So we have both UVA, UVB, and actually UVC rays. UVC mostly gets absorbed in the ozone layer. Hopefully, as that changes over time with global warming, we won't be seeing more issues from that. But for the most part, the rays that we get exposed to on a daily basis are UVA and UVB. So UVA rays are often sort of disregarded because they don't predominantly contribute to skin cancer risk, although they do somewhat, but they do contribute mostly to our photoaging risk, which we'll touch on some of those signs. And UVB is the main contributor to our skin cancer risk. When you're looking at the SPF of a bottle, which we'll touch on, predominantly in the US, the SPF measure is just a measure of UVB, and that's why it's important to look for mineral-based sunscreens. So here you can see on the spectrum what I was just discussing. So now a little bit about those changes that we term photoaging. So that can include a variety of changes. The longer we have cumulative sun exposure in our lifetime, we start to get a amount of damage in the skin cells. And when we're young, our skin is able to repair them. But as we get older, we lose the ability to self-repair those damaged cells. And that may lead to things like precancers and skin cancer, but also to things like brown spots or sunspots, wrinkles, fine lines, textural changes from the skin getting thinner to the skin getting crepier on the surface as well. So some cosmeceuticals that I think are really important to include as part of a daily regimen. I included some photos here for you guys as well. So the main one, of course, again, the SPF. I can't overemphasize how important it is to stick to that regimen every single day, even if you're not leaving the house to put it on, because no one lives in a dark bubble, and we're always getting UV exposure through our windows, whether it's at home, in our car, when we walk the dog, we go to the mailbox, we run an errand. So it's integral to make that part of a daily regimen. Not all SPFs are created equal. So as dermatologists, we prefer mineral or zinc and titanium-based sunscreens. Those are physical blockers, meaning that a chemical sunscreen, which are the other category, most sunscreens on the market, they absorb the UV and are able to basically keep the reaction that it would create normally to the skin from burning the skin, etc. A physical blocker, as it sounds, is a barrier, so no UV at all can come through. So it's more complete in covering the full UV spectrum. and also much more protective for longer periods of time. So especially in a sunny climate like Florida, especially if someone's prone to pigmentation or skin cancers, and especially if you're doing outdoor activities where you may be sweating, it's going to stay in place longer. So Elta is one of our favorite brands. We carry it in the office. I think you'll find it in most dermatologists' office because generally as a group, we love it so much. Now, in terms of antioxidants, so this is a common question. And over the last couple years, because of some scientific evidence, almost every brand you can imagine has their own form of vitamin C. You'll find it at the drugstores, you'll find it at Sephora. But really, it's a trio of 3 vitamins, vitamin C, E, and ferulic acid, when they've been clinically studied, have been shown to prevent further signs of aging because they prevent free radical formation in the skin. They also can reverse some signs of aging, like some small sunspots, and they can actually make our sunscreen work more effectively. So this is important and really suitable for almost every skin type to incorporate first in the morning, followed by the SPF. And the third thing that has the most scientific evidence topically would be either a retin-A, the generic term would be tretinoin, or a retinol. So these products are vitamin A derivatives, and overuse in a 6-month period have been shown to actually stimulate new collagen formation in the skin. And there's really nothing else that's been studied that can make that claim. So in biopsies of skin after someone's been using retin-A for a period of time, there's actually an increase in new collagen fibers. Now, retin-A is the prescription version, may not be suitable for everyone. And that's when the expertise of your dermatologist is very useful to judge your skin type and to suggest perhaps, if not retin-A, maybe in a lower strength, but still medical grade retinol. So other scientifically proven cosmeceutical ingredients that we can use for skin hydration and plumping. So even in Florida, many patients still get dry skin, especially in the winter when the humidity levels are lower, but year round, and that depends a little bit on our genetics and skin type. So hyaluronic acid is a naturally occurring sugar that's found in the skin. And it actually is around our collagen, and it helps plump up that underneath the skin layer called the dermis. And so hyaluronic acid is the same thing that most fillers are made out of, like Juvederm and Restylane, that we inject in a sterile form. But when we use it topically, it actually draws water to the molecule. And if it's on the surface of the skin or creeping into the top skin barrier called the stratum corneum, it'll actually make the skin look plumper and more hydrated for a longer period of time. Ceramides are another naturally occurring, basically lipid or fat, that's found in the skin. And in certain conditions, like patients who are prone to eczema or rosacea, they actually have a diminished amount of ceramides. So especially in those conditions, or with patients who have very dry skin, incorporating a moisturizer with ceramides is also very beneficial. And then there are things called glycosaminoglycans. And these are another naturally found sugar in the skin. And in a product like this one on the right-hand side, the Sente product, they can actually and have been shown to help stimulate new collagen production, as well as to improve the texture and sun damage on the surface of the skin as well. So these are just some products that I love that include some of these ingredients. And a lot of times we like to layer things. So we might include, for someone who has dry skin, maybe a regimen where they're layering the hyaluronic acid gel first, followed by maybe a ceramide containing cream second. That way we're really sealing in the moisture. Now, a common problem that we see in patients in Florida, of course, is brown spots. Because we live in Florida, we're in the sun year round, and despite the wide variety of sunscreens available, unfortunately, the more cumulative damage that we get, the more likely we'll develop either sunspots, which we call lentigines, or what's called melasma. So melasma is a little bit different. It's more of a blotchy appearing brown pigmentation that's very common on the cheekbones, the upper lip, the forehead. And it's much more common in women, unfortunately, than in men, sometimes brought on during pregnancy or birth control use. But for the most part, those of us who've had more sun exposure in our younger years tend to be prone to it, especially now that we're still out in the sun quite a bit. So one ingredient that I like to incorporate that's suitable in some forms, even for sensitive skin, is various forms of hydroxy acids. So that encompasses kind of the spectrum from salicylic, which is more suitable to acne-prone skin or oily skin, lactic acid, which is going to be one of the more gentle, glycolic acid, which is going to be in between and helps exfoliate, and one called mandelic acid as well, which is also helpful for acne prone skin. So I like, for someone who has normal or non-acne prone skin, a blend of glycolic and lactic acid can be very helpful for exfoliation and also helpful for lightening pigmentation. Now, in terms of really hitting the pigmentation hard, we usually have to go to some prescription products and some blends that we make. So hydroquinone is kind of a mainstay of lightening pigmentation, especially stubborn melasma, and has been so for years. We usually have to go stronger than even what's available commercially as a prescription, and we can blend that in the office or send it to a custom pharmacy to create a basically lightening concoction that's going to be suitable for that patient. We might also include ingredients like kojic acid, arbutin, or tranexamic acid. And these are ingredients that are non-hydroquinone based. And the goal is always to use something strong like hydroquinone for a few months' time, and then to wean someone off into a maintenance regimen like some of these ingredients to maintain the pigmentation from coming back. So, of course, as I already discussed, another really important reason why SPF is so important is our skin cancer risk. And I always tell patients who are resistant to sunscreen use that if you use it on a daily basis, you'll reduce your incidence of skin cancer, specifically melanoma, by about half in those areas. So that's pretty compelling data. And 1 in 5 Americans will develop skin cancer in their lifetime. And if you narrow that down to a Caucasian population, especially that we have in this area, who gets a lot of chronic sun exposure, we're probably closer to approaching 50% of people. So a little bit on skin cancer, because we can't do a talk without discussing it. So 1 person dies from melanoma every hour, and more than 3.5 million non-melanoma skin cancers are diagnosed in more than 2 million people every year. So skin cancer risk factors, as you can imagine, being lighter skin, getting either acute sunburns or chronic sun exposure is a risk factor. Having a lot of moles and also that running in the family, and a family history of skin cancers as well, can be very concerning. So there are 3 main types of skin cancer. There are others outside of these 3, but these are the ones that typically we bring up because they're the most common. So basal cell carcinoma is our #1 leading cause of skin cancer. It usually presents like this picture on the left-hand side, and it often looks, as we call, pearly, so sort of translucent or shiny on the surface, and often has these little broken capillaries. If you look very closely, usually you can't identify them with the naked eye. It may just look to the layman like a pink pimple or a sore that isn't healing, and they often bleed very easily. Versus the squamous cell carcinoma type is our second most common, like the picture in the middle. This is a variant called a keratoacanthoma, which appears like a crater, essentially, and they often erupt very quickly. So something like this that looks like it would have been growing for years, it often can come up overnight. And I've had patients develop these even 2-3 times the size of the one in the picture very, very quickly. Now, melanoma, I think almost everyone has heard about, because it's our most dangerous form of skin cancer in terms of the highest mortality. So some of the risk factors that you should be looking for at home, and when you come in for a skin exam, some of the things that we're observing the moles fall in this category of these A, B, C, D, E's. So A stands for asymmetry. So if a spot is able to be cut down the middle and equal on both sides, symmetric on both sides, that's a good sign, versus if it's unequal. The B is for border. So if it's a nice smooth border, that's a good sign again. And if it's irregular and jagged, that can be very concerning. VC is for color. So a nice brown color or uniform one color is very reassuring, and multicolored, especially very black, but even containing different shades of brown, blues, reds, etc., can be very concerning for melanoma. The D for diameter is more so if something is enlarged past the size of an eraser on the end of a pencil. But that being said, a lot of patients do naturally, genetically have a tendency towards larger moles. If something starts small and evolves into that, or changes in color over time, that's where the evolution comes in, is very concerning for melanoma and needs a biopsy as well. So skin cancer prevention, it's never too late. I often have patients who are, age 50 and above, who come in for a skin exam and maybe they've already had skin cancers, and they say it's, too late for me. I've done the damage. What's the point of the sunscreen? But like I said, that damage that we have in our lifetime that leads to these is cumulative. So yes, we do a lot of damage in our younger years, in childhood, in adolescence, and maybe even young adult years. perhaps in a generation that didn't really grow up with sunscreen. But the daily sun exposure, like I mentioned, we get on a daily basis through the window glass, in the cars, at home. A lot of my patients golf and do tennis. It really adds up. And over time, you start to get enough damage where these precancers and then subsequently skin cancers start to come out. So really important to apply a broad spectrum, like we talked about, mineral-based, zinc-based SPF of at least a 30 every single day. Trying not to go out in the middle of the day. So if you are a golf player, a tennis player, you like outdoor activities, you like to run, better times to do that, probably in Florida, realistically before 9, and probably realistically in Florida, probably after 4. Reapplying sunscreen is often the step that people forget. And zinc sunscreens stay on your skin longer until they're kind of rubbed or washed off. But most chemical sunscreens actually are only effective for about 2 to 3 hours. So that means even if you haven't sweated, if you haven't been in the pool, you're basically not protected anymore after that point. Really important to protect your eyes with sunglasses as well, and your scalp with hats, and also your arms and upper body. If you're just doing an outdoor activity, a sport, wear an SPF shirt that has long sleeves, or the same in the pool. We're so good these days about protecting our kids with they're all in rash guards, but we should all be that careful with ourselves. Avoiding sunburns obviously is intuitive, and tanning beds, we didn't really touch on before now, but is a huge risk factor, much more than just sun exposure at the beach, for developing melanoma over time. So definitely that needs to be avoided. Performing a self-skin exam, even if that's glancing yourself over in the shower once a month. Having your spouse or significant other glance at your back where you can't see to make sure that nothing has changed is really important as well. And coming in once a year for a skin exam. There's no hard and set criteria on this, but in Florida, unfortunately, I have so many patients in their 30s, 40s who start developing skin cancers. I think it never hurts to just come once a year for an examination to be sure. So other things, speaking of skin cancer risk, that you can do for supplementation that can help diminish that risk. So this is really interesting, and I bring this up to many of my patients who've had multiple basal or squamous cells. But actually, in the last year or two, there's been some scientific articles written on this, that vitamin supplementation with a vitamin called nicotinamide, which is a form of a B vitamin, and this dosage, 500 milligrams twice a day, has actually been shown to decrease the incidence of these skin cancers by 30% and reduce the incidence of precancers. Heliocare is one that's available over the counter, and we have it in our office as well. And it does contain this nicotinamide, and it also has other natural ingredients that help prevent sunburn and damage by UV to our cells. And there's something we do medically in the office called blue light. It might go by. The official name is photodynamic therapy, or PDT. It's something that generally the insurance will cover. And it's a treatment. Most often we'll use it on the face or the scalp, but it can be used on chest or forearms, or sometimes even legs, that basically is diminishing as many precancers in an area as we can in one session. So this might not be for everyone, but if someone has a frequency of getting frozen in the dermatologist's office, the blue light is very helpful in reducing the chance of further skin cancers in the area and the chance of further things needing freezing. So one thing I've seen a big uptick in, specifically in the last year with COVID, has been telogen effluvium, which I know is a long name. And this is hair loss essentially from a stressor. So that can be an emotional stressor, that can be a surgery, that can be an illness or a new medication. With COVID, it can happen after getting COVID. It can happen after the vaccine. But it's something that comes on usually about 3 to 6 months after these stressors, and usually lasts about 3 to 6 months. So hair loss is a very common condition that we tend to see patients in the office for. And it's important to first have it evaluated by a dermatologist. And sometimes if it's ongoing, to make sure there's no underlying issues, like a thyroid issue, an iron issue, or a vitamin D issue. And typically for something like this, some might take a watch and wait approach because it usually does self-resolve. But if it is persistent or someone is shedding quite a bit, the things I would recommend starting with might be things like the Rogaine over the counter, the Nutrafol vitamins, which are for a hair supplement for hair regrowth, and maybe even PRP injections, which is where we take your own blood, spin it down to get the plasma, which has basically growth factors and platelets, and then re-inject it into the scalp. And this is a great treatment also for androgenetic alopecia, which is male or female pattern hair loss, and something that works quite well in a series of treatments. So other more fun treatments or treatments to improve our skin health and reverse signs of aging, we'll touch on some of those next. So whenever I'm assessing a patient, we sort of have about 3 main categories that we might want to work on with the skin. So one issue is often what I would term a color issue. So are there brown spots? Are there melasma? Is there redness to the skin, maybe some rosacea or broken capillaries from sun damage? Then the question is, are there textural issues or pore size enlargement? And then thirdly, how many wrinkles do we have? Are they wrinkles in areas of movement like our forehead and eyes? Or are they wrinkles maybe around the mouth or maybe on the cheeks? So it's variable where someone develops some of these. And one person might have all 3, one person might only have one of these issues. So treatments to improve, as I term, the color issues. So in our office, we might use a variety of modalities, and it depends on what the patient needs. So on the top left-hand corner, you can see this is a patient that was treated with a series of IPL treatments. So IPL stands for intense pulse light. It's a very low downtime type of a laser. And the brown spots with this turn a little bit darker temporarily, about 5 to 7 days, and diminish. But you can see how many of those over a series of treatments. It's amazing what it takes off. It's ideal for patients who have lighter skin, no melasma, and have darker brown spots. Now, Clear and Brilliant, which is below, is a little bit different. It's a lighter resurfacing laser. So that might help with some early fine lines, some pore size enlargement, as well as some very faint or lighter brown spots as well, like this patient had. Something called photofractional we do in our office is a combination of IPL and a Fraxel wavelength type laser called Resurfix. It's going to be a little stronger than IPL and a little bit more collagen stimulation than the Clear and Brilliant even. And then if someone has more of a vascular component, like rosacea, broken capillaries, we might use other lasers in our office like XLV, which is more specific for the capillaries, or pulse dye laser, or laser genesis for mild pinkness. So like I mentioned in the second category, so texture and pore size. Again, this is a common concern, whether it's that the skin is dehydrated, needs exfoliation, whether that's the skin has gotten thinner over time and has more crepey skin texture or fine lines, but a variety of things can be helpful. So in the first set of things, a regular facial procedure outside of a basic facial, but more of a treatment like hydrofacial or Geneo are some of my go-tos for that. So hydrofacial, for those who don't know, basically uses this vacuum-assisted technology to suction off all the dead skin cells on our skin and even clear out the pores. So it literally sucks all the blackheads out. It's very popular because there's absolutely no downtime with it, and it leaves the skin looking amazing, and you can imagine the pores really cleaned. Geneo is a different facial system that we offer as well, which uses basically exfoliation and ultrasound technology for firming. So it leaves the skin very much exfoliated and hydrated and plumped as well. Chemical peels, we also utilize that to help with the overall texture, whether that's maybe little clogged pimples or what we call comedones. Again, the dry skin, the exfoliation purposes, maybe that's to help with pigmentation. Something interesting in our office that we also offer is called microchanneling, which is different than microneedling. Microchanneling is a little device where we insert a custom blend of what we want to treat and ingredients that will do so. So for example, we might put in a blend of antioxidants and hyaluronic acid for plumping and brightening. We might put in a touch of actually Botox or even a drop of filler in there for, again, more plumping or more contraction around the pore size. Microneedling is a little bit different, a little bit more downtime, maybe about 2 to 3 days. And microneedling is more for collagen stimulation. So it's a little wand that after the skin is numbed, glides over the skin and basically pokes little micro channels in the skin. And basically, in essence, that's stimulating collagen in the dermal layer. So promoting collagen stimulation is going to help with fine lines, it's going to help with acne scars, and it's going to help with overall texture. And then Clear and Brilliant is one of our favorite lasers in the office. It runs pretty much all day long. It's so popular, but it's a very light resurfacing laser. I already mentioned it once in the context of the pigmentation, but it also helps with collagen stimulation, and it helps with, again, fine lines, acne scars, pore size, and things along those lines as well. And downtime only of about 12 hours of pinkness. So So it's very easy to incorporate even in a Florida type lifestyle. So these are some examples for you. So the third category is treatments to improve wrinkles. So again, I mentioned it depends on where those wrinkles are located. So this is an example of two patients that were treated with Botox, and the one on the left is her smiling before Botox and smiling after Botox. And you can see, even though she's a young patient, it significantly improved the eye appearance and I think made her look significantly younger, or I think she looked older than her age because of the lines she had, we'll put it that way. The right-hand picture is a patient whose forehead and glabella were treated. The glabella is our 11-line area, or the area between our eyebrows. So when Botox is used in this area, it helps prevent that scowling appearance. It helps soften the 11 lines. It'll help the horizontal lines on the forehead. And for some patients who need it, it might even give the brows a little bit of a lift. So the bottom picture is her trying to elevate, which is why her brows are a little arched. But if she was relaxed, they would be completely, perfectly in their position. They should be a neutral position. So Botox and Dysport, I often get asked questions, what's the difference? And I was just saying to a patient and a friend of mine today that, Botox has been around a very long time, more than 20 years. There's no significant long-term data to suggest any harm whatsoever in the long term. And for cosmetic purposes, there's never been anything more concerning reported than basically an eyelid or an eyebrow drooping. Now, that being said, the eyebrow drooping or heaviness is a little more common in someone who already has a little heaviness to their eyelid or heaviness to their brow, which is why we might choose sometimes not to inject their forehead for that reason. The eyelid drooping, I've never had any patient have it happen. With proper technique, that's something that shouldn't happen. So it's very infrequent, very much not a reason not to consider it. I know a lot of patients are often hesitant. I have patients all day long who are new to Botox who come in. And I've never had anyone tell me at the end of the visit that it was as scary or anywhere near as painful as they had built up in their mind. You can barely feel it with the small needles that are used. And interestingly enough, if you started at the right point in life, when you're just starting to see fine lines at rest, it's going to prevent us from getting those deep lines over time and basically eliminate basically having those wrinkles later in life, which is pretty amazing. So now we consider it as part of more of a preventative regimen. That doesn't mean you need to start it when you're 21. That means you need to start it at the point in life for you that you start to see the fine lines. So that might be for some patients 25. That could be for some patients 39. It just depends on where they are in their genetics. Other treatments that we use to improve wrinkles, like I mentioned, depending on the area of the face. So hyaluronic acid, we touched on as a topical treatment, but it's also, like I said, in a sterile form in fillers like Juvederm and Restylane. So I actually train for the company that makes Botox and Juvederm, so I can tell you lots about them if you have more time. But in essence, the very low risk of any adverse reactions with hyaluronic acid-based fillers. They give a very natural result, and they last on average of about 9 months and sometimes up to 12. So these are examples of different patients that we've treated, different age categories. The top, we've treated her cheeks. You can see more lift there. It's also lifted her smile lines, which we also treated. We treated the corners of her mouth, which are more lifted in that photos on the right-hand side, and even a little bit in her chin and jawline to define that better. On the bottom left, we treated, again, that patient's cheekbones, her smile lines, and around her mouth and marionette lines as well. And the same on the right-hand picture. So I often find, and it's very common, we start to lose volume in our cheeks over time. And a lot of patients don't see that. What they see on themselves are the smile lines, but it actually is a result more so of the volume loss superiorly in the cheek. So if we're not looking there and addressing that in a way that's natural, like we did in these photos, we're filling in the lines, but we're not making the face more youthful. So it's really important to go to a board-certified dermatologist or plastic surgeon in regards to a consultation to determine what's the best treatment plan for you. And even though you might be focused on a particular area of concern, like a particular line, it's important to be open to their qualified suggestions because, like I said, there are areas of the face where replacing lost volume will really make the face look more youthful, and the cheeks happens to be one of them. Interestingly enough, there's also scientific data that shows that filler placement with hyaluronic acid has actually been shown to also stimulate new collagen production. So even though that filler is temporary and there maybe up to a year, the collagen stimulating effects are going to be there in the long term as well. So another set of procedures to help improve wrinkles would be lasers or other forms of collagen stimulating procedures. So this is an example, obviously, of a patient a little bit in an older demographic who had more sun damage. She had precancerous damage, more fine lines, more pigmentation. Obviously, at this point in life, she was not looking to look like she was 20, but we wanted to clear up as much of the sun damage as we could and help with some of the fine lines and crepey skin texture. So at this point, this is a patient we opted to treat after a discussion with something called a fractional CO2 laser. So there are different categories of laser, what we term ablative and non-ablative. So CO2 is ablative, and that means it's basically burning little teensy microscopic holes in the skin as it passes over little columns of energy, versus non-ablative is heating little columns in the skin, but has less downtime. So ablative is going to give you better results, but we always these days use lasers of what we call fractional technology. And I often get asked what that means. So the old generation of these type of lasers that were non-fractional, imagine it like shining a flashlight over the skin. So the entire area covered by the beam is going to basically be burned off, which is why the recovery was very long. There was risks of scarring and other issues with it. So fractional means imagine shining a flashlight through a cheese grater. So there's going to be little columns of light that are reaching through to the skin, but there's a portion of the skin that's not treated, which is why it results in less downtime, but still really fantastic results. Other lasers for younger patients or patients maybe who aren't ready for something that invasive might be the photofractional we discussed, which is also collagen stimulating. I would say that's most appropriate probably for patients from their 40s to 60s. And the clear and brilliant laser that we mentioned as well, which really I have patients of all ages who love it because, like I said, the low downtime. But I would say that's an amazing laser to maybe start in our 30s. It's one of my personal favorite ones, and continue on really in any age group. It's also a great one to do after the stronger resurfacing. So after you do something like this fractional CO2 on the right, of course, we don't want to just do nothing until we have to do it again. So keeping up with some of these milder laser treatments on a regular basis a few times a year is going to prevent us from needing something as invasive again down the road. Microneedling, we discussed a little bit, and sometimes we'll combine that with PRP. Again, when we draw the blood, get the plasma and inject it. So we talked about it for the scalp, but actually it's been shown scientifically to improve collagen stimulation in the skin as well. So that's a really popular treatment, more in the mechanical category of how we induce collagen. And then tightening wise, we utilize often treatments with radiofrequency. So radiofrequency works by basically heating deeper in the skin. It doesn't affect the top layer of skin like lasers or microneedling does. And it heats deeper to also basically produce new collagen and new tightening, and sometimes as deep as around the lower layers below the fat and to the basically tissue that surrounds the muscle for tightening even deeper. So body treatments, I think, was important to touch on because a lot of people don't realize how much improvements we've made in body treatments over the years. So we now have treatments, and in our office, we offer all of these for fat reduction, like cool sculpting. So a lot of people, I think, have heard of cool sculpting, but did you know that the results are actually permanent with it, which is amazing? It's based on a theory of cryolipolysis, which basically, to sum it up, is when the fat cells crystallize at a certain temperature and then are eliminated through the body. We can use it in areas like under the neck if someone has fullness there from basically the fat cells or the adipose cells. So you can see some examples of patients that we've done their neck, which I think is pretty life-changing. It's one of my favorite areas to treat because a lot of people don't realize it can be treated with something like cool sculpting. And obviously, all the common locations you would think about can be treated as well. So we can treat the arms, we can treat the bra fat area, we can treat the flanks, the love handles, the stomach, the inner thighs, the outer thighs, banana roll, all kinds of places you wouldn't even imagine, like above the knee. And then muscle toning, that in the last couple of years has been a whole new renaissance of the field that we really didn't have treatments for before. So in our office, we offer Cool Tone, which is made by the same company that makes cool sculpting. And it's a muscle stimulation device, and it helps create abdominal definition or definition in the gluteal area, and it can be used on the legs as well. And it doesn't even hurt. It just feels like contractions basically in the muscle. and you do a series of 6 sessions and then some maintenance. Skin tightening, I mentioned with our radiofrequency device, allows us to pair that with any of the above treatments. And something that's brand new is treatment for cellulite. So we've been using our radiofrequency and something called Z-Wave to treat, often on the butt or on the legs. But now we have a new option. There's a new product that just launched called Quo that is an injectable that actually basically dissolves the little bands that create those dimples of cellulite on the butt. So right now it's just FDA approved for the buttocks area. So we might pair that with the other treatments on the legs to create a complete package. So I often get asked from people what I personally use and what I personally do. So I always like to touch on that because I think it's kind of fun and I don't mind sharing. So in the morning, I pretty much follow all these rules. I use an antioxidant serum, again with the CE ferulic acid. And currently I've been adding in a prescription skin brightening formulation. I'm actually allergic to the hydroquinone, so I can't utilize that, but I can utilize these other ingredients. So I'm using one that's a blend of kojic acid and tranexamic acid and niacinamide and azelaic acid. And we have a great compounding pharmacy locally, Delray Shores, that we utilize for a lot of prescriptions like this. And then I'll layer in my Elta sunscreen. That's an SPF of 46. And it's a zinc base with a tint, which is amazing. And then I use a non-tinted one for my chest and my arms, which is really important not to forget those areas. And an antioxidant eye cream for brightening as well. And then in the nighttime, I will usually use a retinol a few times a week. My skin is a little sensitive and I have rosacea, so that might not be every night for me. And then I like to layer both the hyaluronic acid serum with a peptide and ceramide containing moisturizer, again for the hydration, and then a retinol eye cream because, again, we want to stimulate the collagen. And then usually about twice a week, I'll use some form of a hydroxy acid exfoliation. Again, usually for me with something like lactic or glycolic or mandelic acid. Treatments that I like to do, I try to make time to do them. And sometimes, even though it's my office and we have all these fun things, I don't always find the time. But ideally, a facial like hydrofacial and dermaplaning, which basically takes off all the little peach fuzz and exfoliates the top surface of the skin, is one of my favorites to do together. And then about every 4 to 8 weeks, my philosophy is to rotate a collagen stimulating procedure. So obviously I have access to some of these fun tools and toys. So when I had more significant rosacea, I did more regular once a month treatment of some of these to control it. But now I like to alternate something like Clear and Brilliant, which will help with some of my little touch of melasma I'm getting, or Exilis radiofrequency for tightening, or even IPL for some of my sunspots and rosacea. And I do try not to neglect the chest and the arms because that's an area that gets a lot of sun exposure and damage. And that's a little area that's a little hard to treat in the summertime because of how much sun we get, but treating that maybe a couple times a year at least is a good idea with perhaps IPL. And then usually for most patients, Botox about every 4 months is average. And usually just a touch of filler, and my philosophy is always less is more and keeping things looking natural. So I hope that was educational and I hope you guys enjoyed it. I tried to touch on a little bit of everything. This is our office address and information. And, you know, I have so many wonderful patients in the community. I love Delray so much. It's a wonderful place to be and to be raising a child too. So if anyone has any questions, please feel free to reach out and let me know, and hope to see you soon.
Thank you so much, Dr. Lewis, for joining us today. We do have a couple of questions before you go, if you don't mind staying to answer some. I found myself in the middle of your presentation just kind of looking around and like, oh my goodness, is that new? Is that not new? So I definitely have to make an appointment sometime soon. But so let's go ahead and get started. What strength SPF should I use? You mentioned kind of different, I heard 46, I see 50 and 60 all the time. What is the best strength to use?
So usually what we recommend as dermatologists is to look for at least an SPF of 30. You'll find if you're adhering to my rule of trying to choose a mineral zinc-based sunscreen, you will probably never find one that's below a 30 because it's going to be more protective naturally. So I would say most mineral sunscreens usually fall somewhere between maybe a 30 to a 50. And that's an important thing to differentiate. So look for that range, I would say between 30 to 50, and then look to see if it contains zinc. Really above that, most of the ones that are, let's say, SPF 100, there's a Neutrogena product, it's a minimal increase in efficacy or protectiveness at that range, and they actually don't contain zinc. So they're not going to be as protective as an SPF of 50 that's zinc containing, interestingly enough.
Huh, very interesting, actually. So
Yes.
for our makeup wearers that are watching, I guess this is like a two-part question. First of all, will my makeup interfere with the sunscreen that I'm applying? And secondly, if I do apply sunscreen and then makeup afterwards, is there a waiting period between doing so?
So, okay, so in terms of interference, no. I think, a lot of people think that their makeup SPF is sufficient to protect them on a daily basis, when in reality, there's been studies on that as well that show that we really only apply about half as much the thickness or coverage of the makeup as it would need to get to that SPF on the bottle. So meaning if it's a 15 on the bottle, you're really probably getting, a 7.5. So doing a moisturizer SPF first is important, and then layering it with the makeup is sort of like added bonus. You can think of it like that. In terms of one thing you didn't mention, but I often get asked is if it's a normal day-to-day work day, do I need to reapply the SPF? And the answer is, if at the end of the day you're going out for a long walk in the sun, then yes, I probably would. But again, if you're choosing a mineral-based SPF in the morning and then putting your makeup, it's staying in place. You're not sweating, you're not doing anything. So you actually really shouldn't have to unless you go outside and you start sweating or swimming.
Right.
In terms of a waiting period, personally, I usually just let it sink in where, I probably wait about 5 minutes before I put on the makeup. So that way it just feels like it's settled and it's not still on the surface of the skin, and then you should be fine.
So when applying sunscreen to your face, what I guess you could use like a dime a quarter. How much should you be applying to the face?
So I would say probably about equivalent to dime size would be appropriate for the face. Interestingly enough, I don't know, it's a funny use of a shot glass, but there's the amount needed to cover the whole body with one application is actually a shot glass worth of sunscreen.
Huh.
So I always think it's funny when someone tells me they've had the same sunscreen bottle for months, because one sunscreen bottle, if you sat at the beach all day, which obviously I wouldn't recommend, but some people here do that, they should literally have used their entire bottle of sunscreen probably in one day. That's how much you should be applying.
Wow.
And
Yeah, you definitely don't think about that. I know I'm guilty of having sunscreen bottles around for much longer than probably they should be.
Yeah.
So speaking of the beach and sitting around all day long, as much as we all want to wear a sunscreen all the time, sometimes we forget, and sunburns are a part of that. So do sunburns directly cause skin cancer?
So yes, essentially. So even a tan, but definitely a sunburn is actually a sign of DNA damage to our epidermal skin cells. So every time I inwardly cringe when I see patients of mine who come in super tan. Of course, I'm a pretty nice person. I don't like to be confrontational with people. I just like to gently suggest they use more sunscreen. However, it's basically you're walking around with a sign that says I've damaged my skin. So what happens is, like I mentioned, when we're younger, we're able to repair that damage. And then over time, we lose that ability. And that's why we develop cancers of all kinds, why we start to get more colon cancers in life, or breast cancers, or prostate cancers. So the same applies to skin. And it reaches a point where we've created so much damage. So even though the sunburn isn't at that moment creating a skin cancer, it's that cumulative effect of the damage. And of course, a sunburn is going to result in more damage than just getting a tan.
Right. And has there been any research, or is there any way to know, okay, I've had 50 sunburns in my life, now I probably have skin cancer, or is it different per each person? How does that work?
So, 50, I would say the odds are high. So that person is probably going to develop, a skin cancer in their lifetime, but it really depends also on our genetics because, I hate to say it, but my mom is more of a Mediterranean background. She's from Europe. And thank God she's listened to me, and now she uses her SPF 30 in the last 5 years. I finally convinced her. But, she's someone who likes the sun. She's better than she used to be, but she's had a lot of sun in her lifetime, and she has yet to pop up with something. And I have patients like that as well. And then sometimes I have patients who are a little more Mediterranean skin type who pop up with lots of things. So it really depends on the genes that we inherit that make us predisposed to certain conditions in the skin. Whether the likelihood of that DNA damage is going to translate into a skin cancer. But statistically, those of us who are fair skinned like you and I are going to be the most susceptible.
Yes, I am definitely a hat wearer and a shade down in my office person.
Perfect.
So I actually have a question from one of our Facebook viewers, and forgive me, that's kind of why I'm looking down. And I hope I'm going to word this correctly. What does the doctor think of tan sprays, especially having an in-situ melanoma removed and a malignant melanoma spot.
Mhm.
Hopefully I worded that correctly.
Yeah. So the spray tans or the at-home tanners, I mean, personally, I've never loved them because I feel like everyone I've ever tried makes me look orange. So that's a different conversation. In terms of data on safety, I haven't seen any evidence that there's a higher risk of skin cancer using them. Now, that being said, I mean, if you look at the bottle of those, I mean, it's a lot of chemicals that get put into those. I don't know personally. I think on a one-off here and there, using it, I think is fine. I honestly just worry, and it has really no scientific basis that I know of. But putting something like that on yourself every single day, I just don't know if I love the idea of that, because those are fairly relatively in the scheme of data we have on cosmeceuticals, sort of relatively a new genre of products that have evolved in the last 10 years. And so whether that has any long-term difference, I don't know. But as far as we know, I've not seen any data on it. I will say the one thing that is sort of helpful is to maybe not do the tanner before you come in for a skin check, because interestingly enough, the moles and keratoses, they actually preferentially sort of absorb that stuff. So when we're looking at them, they often can look darker or different than their baseline state of the mole because of the self-tanner. So it's helpful if someone comes into the office for a skin check without it.
Oh, that's fascinating. I would have never thought that.
Yeah.
Okay, so let's talk about the stress that you were talking about, and losing hair and things along those lines. Do the effects caused by stress reverse when the stress has gone away? Will hair grow back to its original thickness? I know you mentioned, that it's kind of a weight game sometimes, but can you expect if that is the case that it will come back as thick as it once was?
So in a classic version of the telogen effluvium, which is that shedding from a stressor, I would say yes. Sometimes that might not be the case if someone also has something that's compounding the issue. So let's say that they have a thyroid issue that we realize are diagnosed during this, or a vitamin D issue, or iron. Some of those underlying deficiencies or conditions, even once they're corrected, the hair never really gets back to its normal state, especially with thyroid, I would say. But I would say classically, if someone doesn't have anything underlying, yes, you would expect over time it would get back to its normal thickness. It just might take 6 months or a year. And that's where I like the hair vitamins for that. The Nutrafol, I think it's really helpful product for it. The other thing I sometimes see is I have a lot of patients, myself included, with early onset of female pattern hair loss. And a lot of times a stressor might kind of throw them into what looks like a telogen effluvium. They start shedding all of a sudden, but it goes on for longer than it should. And when we take a biopsy, it actually shows a female pattern hair loss. So I have a lot of patients in their 20s and 30s who have sort of evolved or developed into that. And that just requires a little bit more ongoing management and treatment to control it as well.
That's so interesting, because I was actually kind of wondering how, as a dermatologist, you might differentiate what the cause could be. And of course, it makes sense that it's from a biopsy, but I just never thought that you would take your hair, which is kind of fascinating.
I don't think you're the only one, because sometimes when I tell patients who have a rash or hair loss, we should take a biopsy, they look at me confused, because I think people equate biopsies with cancer diagnosis or cancer checking. Right. But every rash has a different pattern of inflammation under the microscope, and every type of hair loss does as well. So that's a way if something's ongoing that we can diagnose. Now, some of it is very obvious clinically, but I would say if it's not clear cut with hair loss and it's been ongoing more than 6 months, I think it definitely needs a biopsy to know for sure what the diagnosis is. And sometimes it's very surprising what they see under the microscope.
No, that's so fascinating. All right, so I think I have one last question. I'm checking Facebook, so I want to give them a second if they have any other questions. But this is a question that some people might not even know, because as you've mentioned, some of your clients come in and they've never been, they're 30 years old and they just thought, oh, I don't have to go. It's not a thing for me yet. Do I need a referral from my primary care doctor to visit a dermatologist?
So for the most part, no. The only exception to that is some HMO plans, for example, something like Humana HMO. So the HMOs operate a little differently, and usually they require the patient to first see their primary doctor and then to get a referral to come in. And there's a lot of primary doctors we work with in the area who are usually happy to do so. I don't think I've ever had, someone decline a request for that. But with the exception of that, pretty much anyone can come in, any age. I have Often patients will bring their kids for skin checks, especially if there's any family history of melanoma, which is perfectly fine. And I always encourage it to just get a baseline and to make sure everything's okay. And if there's anything we're watching, then I'll keep an eye on it. And if they look totally perfect and unconcerning, I might let the pediatrician keep an eye on them too. So really any age can come in.
So would you encourage your clients that are coming in for the first time, or even repeat clients, to make a list of what they might be concerned about, or just kind of go in and hope you spot something?
So I always ask patients when I first walk in, are there any particular concerns, any spots that are changing, bleeding, growing, and any other concerns on the skin? And I would say most of the time the answer is no. Sometimes there's one or two spots they've noticed. I think, unfortunately, people are not that observant on themselves. With the exception, sometimes I'll have husbands come in whose wives have circled all kinds of things on them, which is always kind of comical. But for the most part, I mean, it's perfectly fine to come even if you have no concerns. It's good to come if you have concerns. I mean, making a list is good so you don't forget. You can always go the route of circling things on yourself, but either way is okay.
Well, it can be a nerve-wracking experience, I'm sure. And, you know, I'm sure you make people feel very at ease. Even just listening to you talk today, I feel calm, and, you know, it was great to hear you today. So we thank you so much, Dr. Lewis. I know that you are a busy woman, so we are going to let you go. But I would like to tell our viewers that this has been recorded. It is on Facebook. It will be on YouTube, and it will be on our chamber website. So feel free to share this information with someone. I don't think it could hurt in any way, shape, or form. So even if you think it's not something at the top of their mind, make sure you share it anyways. And thank you again. Have a great day.
Take care.